My name is Jason Pogue. I'm a clinical professor of pharmacy at the University of Michigan College of Pharmacy. I also serve as an ID clinical pharmacist over at the hospital from time to time, but my primary focus at the College of Pharmacy is doing clinical translational research.
And today we're going to be talking about the CACTUS study. So, can you just give us a brief background of how this study came to be?
Yeah, absolutely. So we're very proud of this work. We encourage you to take a read. It just got published earlier this week. The study design, or what we were trying to do, is compare Ceftolozane-Tazobactam and Ceftazidime-Avibactam for the treatment of drug-resistant Pseudomonas in the US. And to kind of set the stage from that, what I would say is that, both of these agents are guideline recommended for the treatment of drug-resistant Pseudomonas. The reason they're both there, so if you look at the IDSA guidance document, you'll find both of those drugs listed. And the reason that they're both there is that they've shown to be superior to historic regimens that we used to give before we had these novel cephalosporins. And so think drugs like the polymyxins or the aminoglycosides. And so there's a lot of real world evidence showing that these drugs are better than those historic options, both with regards to efficacy, but predominantly due to safety, because there's a huge toxicity risk with those drugs. And that becomes an important part of the story because while it's easy, and I use that loosely, while it's easy to show that these drugs are better than the polymyxins because the polymyxins stink, to try to look more closely between are there any differences between novel agents is much more challenging because it's going to be a much more nuanced conversation. Because at the end of the day, these are both cephalosporins and they're both active against Pseudomonas and drug-resistant Pseudomonas. And so while before the CACTUS study, there have been some small publications that have tried to ask this question, is there any difference between the two? While these investigators are awesome and the studies are pretty solid, there are some notable limitations to those that make it hard for them to answer this question. Notably, the sample sizes are relatively small. Some of the studies that are out there, they haven't routinely tested susceptibility to these two drugs, so you don't even know whether or not they're active all the time in patients who got it. One of the big issues is that not a ton of people get these drugs, right? And so often, if you have smaller studies, not a lot of study sites, you really have to take all comers into such a publication. And the problem is that some of those disease states are more or less likely to respond to nuanced differences in therapies. For example, if you include patients with urinary tract infections, if the drugs both concentrate in the urine, then any difference might not be seen between those two agents. If they have intra-abdominal infections and you get source control of that intra-abdominal infection, that's going to limit any difference you would see between two different therapies. And so all of these kind of previous limitations is what we tried to overcome in the design of CACTUS. And so if you look at CACTUS and you look at the publication, think of it with those things in mind. So first off, we included 28 sites in the United States. A lot of leading investigators in the resistant gram-negative space. The reason we did that is because we were going to get good data and that allows you to get significantly more numbers. Secondly, if you look at the inclusion in the study, we didn't take all comer infections into CACTUS. We had only pneumonia and bloodstream infection. And so the reason that we did that was what we just talked about, Sophia. Essentially, we wanted to limit it to disease states that we thought therapy might have a big impact on outcomes. And in particular, with respect to pneumonia, there's some PK/PD differences between Cazavi and Ceftolozane-Tazobactam that we thought if they existed in improving outcomes one way or the other, that would probably be the population. And then the other really important thing, again, doing these types of studies are really hard. Again, they're retrospective, they're observational. You're just looking at what people did in the past and trying to see if it impacted outcomes. But there's a lot of confounding that comes in those types of studies, things like indication bias or residual confounding. And so, what we wanted to do is we wanted to try to minimize that to the best that we can. So if you look at the methods of CACTUS, what we did is we had 28 sites, but the way we tried to minimize the bias in the study is we had our individual site investigators at each individual site match patients. So they actually submitted matched pairs to us. So basically, for every CAS-AVI patient, they had a matched Ceftolozane-Tazobactam patient, and they were matched on severity of illness, infection type, and then the time to getting them started on drug. Because we know all three of those things are going to impact outcomes. And so our thought process was if we can match based off of that, if there's any differences that are still seen, it's really going to be the therapy that's driving that. And so that was how we tried to overcome some of the limitations that you see in the other studies. And then the other thing that I would note, Sophia, is that, again, and I'm a person who published in the past on these drugs versus the polymyxins. And often you would just get however many patients you could in a study, and you'd likely show a difference because of how toxic the polymyxins were, right? You didn't need a ton of patients to show that. When you're talking about two cephalosporins, as we already discussed, it's going to be more nuanced. And so we actually had a hypothesis that ceftolozane-tazobactam was going to be superior because of some of these PK/PD advantages. And we adequately powered the study and able to show it. So we included 420 patients, 210 matched pairs. And the reason for that, Sophia, is that that's how we could adequately test the hypothesis. And so those were some of the ways that with the study design at Cactus, we hope to overcome some of the limitations of previous data and really test a hypothesis to see if there's a difference between these two.